Sometimes this happens when you put Alzheimer's disease and dementia in the title. But anyway, I have lots of disclosures since this is a CME event. We spend 90% of our time on research and discovering new treatments and about 10% of our time in clinical care, mostly to try to find individuals who are eligible and interested in joining clinical trials. And these are the great team of folks that I work with in the memory disorders program. Oh, I should also do a shout out to the clinical research unit staff, which is funded by the CTSA, where all of our research visits are done. So these are our objectives. We're going to talk about MCI, Alzheimer's, and the new treatments and the side effects of the new treatments and the benefits. But first, I'll talk about Alzheimer's past, Alzheimer's present, and Alzheimer's future. So here's the past. 54-year-old factory worker became progressively paranoid, apathetic, demented. She lost weight without explanation. Her exam was otherwise unrevealing. There were no diagnostic tests, no biomarkers, and no treatments to offer. For anyone with dementia, she died in a vegetative state after 7 years of progressive decline. Brain-only autopsy was taken, and brain sections were stained with silver, and they were found to be the brain was found to be full of amyloid plaques and neurofibrillary tangles. And this is what they look like. Here's the amyloid plaque. Here's the neurofibrillary tangle. The amyloid plaque is mostly made up of A-beta peptide protein, and the neurofibrillary tangle is mostly composed of phosphorylated tau protein. These are abnormal protein aggregates, accumulations of proteins that are not normal and are typical of Alzheimer's disease pathology. So this is what our pathologists still do today, silver stained brain sections, counting density and distribution of amyloid plaques and tangles. This was considered a rare disease, and it was written up as a case report by Dr. Alzheimer. And he said, look, looks like there's a disease that's not in our textbooks. And he thought it was incredibly rare, and it was incredibly rare because the life expectancy at that time was pretty short. So it was a case report. And then more recently, Alzheimer's disease is often misdiagnosed as hardening of the arteries, or if it's not written off as normal aging, it's diagnosed as hardening of the arteries or mini strokes or vascular dementia, when it actually is Alzheimer's. Let's move to the present. Now we have a 65-year-old attorney came to clinic with memory complaints. Spouse agreed that there were some problems with memory, forgetting appointments, conversations, repeating questions, losing things at home, constantly looking for these lost items. Got lost driving in familiar territory, could no longer work. And from 23andMe, she knew she was at increased risk for Alzheimer's because she knew her ApoE genotype was ApoE3/4. Exam was normal with the exception of scoring 24 points out of 30 on the MMSE, the mini mental state exam. Blood tests were normal, normal TSH, normal B12, negative RPR, negative HIV. Brain MRI was read as normal for age, meaning atrophy and white matter changes, considered normal. But hippocampal volume was less than 1 percentile when a quantitative analysis was done on the MRI scan. So here's a clear red flag, something causing hippocampal atrophy, cognitive decline, 24 points out of 30. So she had a mild dementia, was confirmed by a full neuropsychologic battery by evaluation with a neuropsychologist. An amyloid PET scan of the brain was positive, which was consistent with a mild dementia due to Alzheimer's. So this is evidence of Alzheimer pathology. She was prescribed donepezil, followed by lecanemab, IV Q2 weeks, which is the new anti-amyloid monoclonal antibody. After a long discussion of the risks and benefits, she had one episode of asymptomatic ARIA-E, which resolved on MRI, but no other adverse effects. And we'll get to what ARIA-E means and what it is. So let's skip to the future. This is going to be very impractical to infuse every 2 weeks all of these patients with mild cognitive impairment and early Alzheimer's with these antibodies. Every 2 weeks infusion, very expensive, very inconvenient. And also just too many patients. We just don't have the capacity really to handle all the patients who could be treated with these antibodies. So we're going to have to move on and develop and discover new things. So what happens in the future? A 50-year-old AI expert knew since early adulthood of his elevated risk of Alzheimer's, including the fact that he was ApoE4/4 homozygous for the high-risk gene for Alzheimer's. He lived a healthy lifestyle to delay or prevent the onset. And this Involves physical activity, exercise, Mediterranean diet, etc. No smoking, no heavy drinking. He came to clinic for a routine wellness exam, and a screening result of his plasma revealed abnormal amyloid, phospho-tau, and other Alzheimer biomarkers. He elected to receive an active vaccine, a vaccine to prevent Alzheimer's, and an amyloid vaccine. And his anti-amyloid titers were monitored, as well as his MRI scans. And over the subsequent years, he had 6 new microhemorrhages, which is ARIA-H, and these were all asymptomatic. And he died at age 96 of pneumonia and sepsis. So here we have concepts of personalized medicine based on genomics, prevention, active vaccination instead of passive vaccination with anti-amyloid antibodies, and compression of morbidity. So we often get the question in clinic, what can I do to prevent Alzheimer's disease? So this is the list of things that you can do, starting with the things that have the best evidence at the top. And these include things like exercise, maintaining ideal body weight throughout life to avoid obesity and diabetes, and eating a Mediterranean diet, etc. So if you do all of these things, you could probably prevent or delay Alzheimer's and other dementias by at least 5 to 10 years. But the problem is you will probably live another 5 to 10 years. And the number one risk factor is aging. So it could still catch up with you, even if you do live this healthy lifestyle. Obviously, there are things here to treat: hypertension, diabetes, high cholesterol, obstructive sleep apnea, depression, and certain things to rule out at the bottom here with your medical providers: syphilis, HIV, B12, thyroid disorder, etc. And also review of medications. A lot of medications could have a negative impact on memories, including like the benzodiazepines. And this was a study looking at how much dementia and Alzheimer's may be potentially preventable, delayable, modifiable. And these were factors: 8% from hearing loss in midlife. So if you have hearing loss, you get a hearing aid. You don't want to deprive your brain of getting the proper sensory information, sensory stimuli. Getting good quality education in early life. No smoking. Treating of hypertension, diabetes, obesity, etc. This particular review suggested that maybe 40% of dementia and Alzheimer's is potentially modifiable, preventable, delayable by these lifestyle factors. But as I said, you can do all of those things and still get dementia. So traditionally, we focused on the dementia category. We're increasingly focusing on the mild cognitive impairment category, the MCI, which is the precursor to dementia. And now our biomarkers have allowed us to discover this new category of patient, preclinical Alzheimer's disease. So how do we separate the people on the solid line from the dotted line in these early stages? And that's where the biomarkers come in to tell us who is who in this line. You notice that there still is a little bit of cognitive decline with aging and is considered normal aging. Where the boundary is and how much cognitive decline is allowed to be called normal aging is debatable. But over the years, we've developed many measurement instruments of cognition and function and behavior, and these are what are used and recommended in primary care screening. There are several tests that have been developed that could be administered in 3 to 5 minutes. So this is something that you could incorporate into an annual wellness exam, for example, or any patient who has a cognitive concern or the family brings up a cognitive concern. In the memory clinic, we do longer tests, 5 to 15-minute tests, such as the MMSE, the MoCA, the SLUMS. We would love for you to do these tests, but we know that they take more time and you may not have enough time in your clinic visit to do the MMSE or the MoCA or the SLUMS. So we would ask that you do one of those shorter tests. We send patients to neuropsychologists, and neuropsychologists have developed a whole battery of tests to measure different cognitive domains, different brain regions, and have standardized scores for patients' age and education. And in clinical research, we've developed a battery of instruments that take several hours and a trained administrator to give. And these are things like ADAS-Cog, ADCS, Activities of Daily Living, Clinical Dementia Rating Scale, Neuropsych Inventory, etc. And more recently, we've developed these composites that are more sensitive to the earlier changes, the mild cognitive impairment changes, so to find treatments for the MCI category. So these are those brief screening instruments. They're available at alz.org. So go to alz.org, search for cognitive screening and assessment. These tests are available downloadable with instructions and norms and even videos about how to administer them. So there are 3 that are focused on the patient, and these are the 3 here. The first one is just a word recall for 3 words, delayed recall, and a clock drawing test. So these are very quick and easy, quick and dirty instruments to do cognitive screening in your clinic. So these are the 3 addressed at the patient, and these are the 3 addressed at the family member, the informant, the partner, because we often get a very different story from the family than we do from the patient. The patient may often say, I'm perfectly fine, there's nothing wrong with me, and the family reports all sorts of cognitive issues and memory problems. So these are the 3, and one of these is a survey that could be done in parallel while you're working with the patient. So again, these are available at alz.org, downloadable with instructions and norms. So pick one of these to give to the patient and one of these to give to the family member, and you will learn a lot about their cognitive status just from these quick screening instruments and whether to refer them on for further evaluation in a clinic or do an MMSE or MoCA or longer test. Recently, we've developed a lot of biomarkers for the disease, starting with glucose PET scan back in 1980s, more recently MRI, and then the more recent technology is amyloid PET imaging and amyloid tau or tangle imaging. These are all imaging biomarkers. We're looking at a lot of proteins in spinal fluid, including amyloid and tau and phospho-tau and neurofilament light. More recently, we're trying to develop blood or plasma-based biomarkers, including amyloid, phospho-tau, epitopes, neurofilament light, etc. They're not quite there yet. We use them in research. They're not really ready for clinical application yet. They're not quite as good as the spinal fluid proteins or the PET imaging. The problem with the PET imaging is it's very expensive. Amyloid PET scan is $3,000, $4,000. Spinal fluid proteins require spinal tap, and patients are not very enthusiastic about getting spinal taps. So we're hoping to develop these blood biomarkers. We do need more research on these. For example, they can change with renal function, and we don't know enough about these markers in underrepresented groups compared to the Caucasian population, for example. But these are well on their way towards clinical application, and maybe in coming years we'll be able to replace the PET scan and the spinal fluid markers. This is when biomarkers become abnormal. So here is when function declines, that's called dementia. When cognition declines, that's called MCI. So there are 2 lines in the sand here between normal, aging, MCI, and dementia. So MCI progressing to dementia at about 10 to 15% per year means that the cognitive decline has reached a level that is now impacting daily function. So that's the threshold for dementia versus the threshold for MCI. But now that we've developed all these biomarkers, we've discovered this new category of patient called preclinical Alzheimer's disease, because they have abnormal biomarkers, but normal cognition. So again, this is another group that we're increasingly focused on because we think our treatments, our new treatments, disease-modifying treatments, will be more effective the sooner we start them in the MCI group or even the preclinical dementia group. And the first biomarker that becomes abnormal is amyloid accumulation in brain, shown here. There's also this sort of ceiling effect. But we think the amyloid triggers the other pathologies, including the tau tangles, which the tau tangles triggers the cognitive decline. And this is sort of the amyloid cascade hypothesis of Alzheimer's disease. This is the effect of ApoE genotype on amyloid accumulation as a function of age. So everyone has one of these 6 possible ApoE genotypes. You can see the most common in the US population and the world population is ApoE3/3, which is sort of neutral. ApoE4 is higher risk and ApoE2 is lower risk or protective. So this is amyloid accumulation by PET scan as a function of age. So here's 3/3. This is the 4/4 homozygotes. This is the 4 heterozygotes. And these are the ApoE2. So those rare people who are lucky enough to be ApoE22 don't develop Alzheimer's or amyloid deposition in the brain. But you can see that ApoE22 is incredibly rare in the population frequency. About 25% in the US have one copy, at least one copy of APOE4. 1 to 2% have 2 copies or homozygous. But if you look at the Alzheimer population, about 10 to 15% are APOE4 homozygous. Any questions so far? Anything you want to talk about? Anything on Zoom? Any questions on Zoom?
Not yet.
Not yet. All right. We'll carry on. These are what the PET scans look like. So here's an amyloid PET and a tau PET of 2 people who are cognitively normal, completely normal, normal cognition, and here's an Alzheimer patient on the right. So this patient is clearly demented, very positive amyloid PET scan, very positive tau PET scan. But we can see these pathologies beginning earlier, 10 to 20 years earlier, before the cognitive decline begins. So here's a patient who's still normal, but we call this preclinical Alzheimer's disease because the biomarkers are now becoming positive. Amyloid is accumulated in the brain, and the tau signal has escaped the medial temporal lobe into other cortical regions, inferior temporal regions. So this is a positive amyloid PET scan, a positive tau PET scan, and yet the patient is still cognitively intact. And here is a typical 65-year-old with some amyloid accumulation, medial temporal lobe, hippocampus, entorhinal cortex, which you need to make new memories. So new memories is the first thing to go in Alzheimer's disease. And a little bit of tau signal is seen in just about anyone over 65. So you can see a little bit of pathology here in the tau PET scan. So this is how we're using these biomarkers for diagnosis, for prognosis, for testing drug efficacy. And these, all of this amyloid PET scan and tau PET scan is relatively new technology. Before this was developed, we had to wait until someone died and look at the plaques and tangles at autopsy. These are the FDA-approved drugs for mild cognitive impairment and Alzheimer's. Everything in green is only approved for Alzheimer's disease and not for mild cognitive impairment. But the first 3 are cholinesterase inhibitors. They block the degradation of acetylcholine at the synapse and promote memory formation. NMDA, memantine is an NMDA antagonist, approved only for moderate to severe dementia. And this, as these things came off patent, this new combination pill came out. Not really a new development, but a new formulation. And you can see there was a long stretch here until we had our next new drug approval, which was July of this year, which is the first anti-amyloid antibody called lecanemab or Leqembi, approved for mild cognitive impairment and mild dementia due to Alzheimer's, or basically early Alzheimer's. And there's another one coming very soon, which we're anticipating FDA approval early 2024, which is also an anti-amyloid antibody, approved for the same indication, probably. And so this is our first disease-modifying strategy for Alzheimer's. Do you have a question? Any questions? No? Okay, so this is our first disease-modifying strategy for Alzheimer's, is lecanemab followed by donanemab. Yes?
So, this new drug, they incorporate all the biomarkers that.
Yeah, I'm getting to that. You also have to prove that there's amyloid there in the brain, either by CSF or PET. Blood test still not quite accepted yet for clinical application.
Thank you.
So this is our first disease-modifying strategy. So this is the APP protein, which is the precursor, amyloid precursor protein, which generates the A-beta. The A-beta changes its conformation to this less soluble amyloid conformation, begins to aggregate and precipitate in brain, probably because the clearance of the amyloid decreases with aging. So this begins to accumulate as neurotoxic, and then triggers inflammatory responses. It's almost like a foreign body, a neoantigen. So you get this immune response, scoliosis, which is part of the disease as well. So we infuse these antibodies. So I'm going to talk now about lecanemab and donanemab, which are really the first antibodies that have been successful. Others have been tried, antibodies that do not clear amyloid from the brain, do not demonstrate a clinical benefit. We've learned that the hard way. But lecanemab and donanemab do clear amyloid from the brain and do have some clinical benefit. And so this is sort of showing that graphically. So here, oops. So here is the amyloid curve. It continues to accumulate in the placebo group at about 1 to 2% per year, or 1 to 2 centiloids per year. Whereas those given the anti-amyloid antibody have rapid clearance of amyloid from the brain. and less than 20 centiloids is considered a negative amyloid PET scan. So you can clear amyloid from the brain after several months of IV infusion of one of these monoclonal antibodies to amyloid. And then after amyloid is cleared, this has an impact on the clinical course. So this is continuing cognitive decline in the placebo group, shown here. And then when the amyloid is cleared, we're bending the curve. So now we're getting less decline in the treated group compared to the placebo group. And at the end of the study, typically 18 months, there's a significant difference in decline between the treated group and the placebo group. You'll note that everybody declined, nobody improved during the course of this study, but there was less decline in the treated group compared to the placebo group. And the antibodies that don't clear the amyloid from the brain do not demonstrate this clinical benefit. So I'm going to talk now about the Clarity study, and Georgetown was a site for this as well, which is looking at the question of whether lecanemab or Leqembi is safe and effective for individuals with mild cognitive impairment or mild dementia due to Alzheimer's. And this was published this year. Funding is from ASI, partnering with Biogen. And skipping right to the endpoints of the study, this demonstrated clinical efficacy in slowing down the rate of cognitive decline in all of the endpoints that were examined: the clinical dementia rating scale, the ADAS-Cog, the ADCOMS, all significantly less decline in the treated group compared to the placebo group. And if you look at the amyloid PET scan, the placebo group continued to accumulate amyloid at about 1 to 2% per year. So an increase in amyloid in the placebo group, but a decrease of 55 centiloids of amyloid in the treated group compared to the placebo group. And this is what it looks like graphically. So here's the continued accumulation of amyloid in the placebo group, 1 to 2% per year, and clearance of amyloid during the 18 months of lecanemab treatment. So there's no doubt, no question about amyloid clearance. Almost all of the patients went from a positive amyloid PET scan to a negative amyloid PET scan. But here's the clinical course. So everybody declined, no one got better, nobody improved, but there was less decline in the treated group compared to the placebo group. And in the primary outcome measure, which is the clinical dementia rating scale, there was 27% slowing of decline. So this is sometimes a bit abstract to explain to patients and families and regulatory agencies and payers. You can convert this to time. So the placebo group declined at the expected rate, an 18 months of decline in an 18-month study, but the placebo group declined 5 months less compared to the treated group declined 5 months less compared to the placebo group. So you convert this to time. And we think, we don't know yet, but these curves will continue to expand and separate even further as time goes on. We don't know that yet. We're collecting that data. But there may be continued benefit. And this suggests that it's a disease-modifying benefit and not just a symptomatic benefit by removal of the amyloid. And the same story for all of the other cognitive outcomes: less decline in the treated group compared to the placebo group. And the biggest effect was on this ADL score, activities of daily living. So this is a measure of function, almost a 45% difference, less decline in the treated group compared to the placebo group. So this is our first successful disease-modifying therapy for Alzheimer's disease. We think there's a lot more in the pipeline. We hope to improve on this. The question becomes, is this really worth it? Is this amount of less clinical decline worth the inconvenience of an IV infusion every 2 weeks? Is it worth the cost? And the total cost estimated for the first year for everything is approximately $100,000 a year. 80% will be paid by Medicare, hopefully 20% by something else. Future years would be less cost. And then, of course, there are the risks and side effects, and we'll talk about the side effects. So does anyone have any opinions about whether this is worth it or not? Would you sign up for this if this were you, if this were your patient, if this were your family member? Would you sign up for this treatment? And I know you haven't got to the side effects yet, but does anyone have any comments?
Is there any chance you can get to the maybe a 4.4 risk group, and if they have just a light flicker of a PET positive, so an early treatment, you might have an impact. Can we market that?
We're looking at that. We're doing a prevention trial of people who are cognitively normal but have an amyloid PET scan positive. Many of these people have a genetic risk or family history risk. So we're doing this prevention trial with the hypothesis that if we start sooner, before there's any cognitive decline, we'll have a greater impact. We don't know if that's true or not. We won't know for a few more years. But we are looking at these biomarkers to detect the disease early and to start treatment earlier. And we think if we started treatment earlier, we would have more benefit. So, but this is the start. This is just, our foot in the door, our first drug treatment demonstrating a disease modifying benefit. Anyone have any opinions about whether they would do this? Yeah.
There's a big difference, as you know, between clinical importance and statistical significance. And I wonder how much in terms of patient-reported outcomes you have data to say that this actually makes an observable difference to the patients and families, even if you can, on your testing, show a very small difference in rate of harm.
Yeah, some of our outcome measures look at sort of clinical impression, global clinical impression, and these are blinded observers. And they have suggested that there is a significant clinical benefit, not just a statistical significance, but clinical significance in these results. So it's debatable about how to translate this into like day-to-day function. And is this like 5 months more recognizing your spouse, or finding the bathroom in your own home, or being able to use the stove? These are like the way the clinical dementia rating scale has a lot of functional measures such as this. Can you use a telephone? Can you use a stove? So preserving 5 months out of 18, is that enough to warrant the risk, the cost, and the inconvenience of this? That's sort of where we are now in the debate. Yeah.
It would also just strike me that the problem is probably multimodal. So you have one target and you're effectively hitting, and it slows things down, but there's probably other targets. And so
Yep, you're absolutely right. Yeah. So even though the amyloid is removed, the patients are continuing to decline. So we think that the amyloid is like triggering these other pathologies, which then become independent of amyloid and causing the cognitive decline. And one of these is probably the tau tangles. So we need probably to develop polypharmacy and have more than one target, not just amyloid, but perhaps tau and inflammation and other targets to really make a more of an impact on the curve, bend the curve even more. But as I said, this is the first shot, and there are a lot more coming, and a lot more coming in the pipeline with additional targets. As you mentioned, tau has been a particularly hard target to get to. We've tried antibodies, we've tried other things, and so far nothing is really moving tau if you target it directly. But some of these antibodies are moving tau, and I'll show you that later. So even though it's an anti-amyloid antibody, it's having a positive outcome on tau measures. So this sort of supports this amyloid cascade hypothesis. But clearly we need to do better than this, and we hope to. And if our other treatments work in addition to lecanemab with additional targets, then we'll have a bigger impact.
Can I ask one more question?
Yeah.
Going back to the consent, or would you do this as a patient? And I guess I'm wondering about the cognition of the patient. Is it the patient able to consent to this, or is this a family making a decision on behalf?
And just a request from the virtual group, they ask for you to repeat the question.
Sure. So the question is, can the patient consent to these studies, or is it from the family? These are patients who are very early Alzheimer's disease, mild cognitive impairment, meaning, just a little bit of cognitive hit, but normal function, and early dementia, mild dementia. So MMSE is 22 to 30. So these are patients who are very capable of making their own decisions and giving their own consent. At the same time, we also get consent from a family member because we know they're going to progress and decline, and at some point they will not be able to give their own consent. And so we get consent from the patient and the family member, or spouse, or legal authorized representative. And at this point, they're very capable of making their own decisions. Other question or no? So here are the side effects. So not only do we have the inconvenience and the cost, but there are side effects of these antibodies. And the first side effect is an infusion reaction, which was found in 7% of placebo and 26% of the treated group. And this is from infusing a monoclonal. You get sort of temporary flu-like symptoms, nausea, aches and pains, etc., usually lasting only a few hours, usually pretty mild. If they're more severe, we can pre-medicate. So not really a major issue, but that is one of the side effects. The more concerning side effect is what we call ARIA. There's ARIA-E and ARIA-H. ARIA is amyloid-related imaging abnormality. E is edema, and H is hemorrhage. So ARIA-E was 1.7% in the treated group and 12%, 1.7% in the placebo group and 12% in the treated group. And this is edema or inflammation as a result of the antibody removing the amyloid. And if you have a symptom, the most common symptom is headache, but most of it was asymptomatic. And then there's this curious phenomenon that if you have an ApoE4 gene, you're much higher risk for ARIA-E. So this is shown here. So this is non-carriers, 5.4% risk of ARIA-E. Heterozygous, 10.9%, and homozygous, 32%. So ApoE4 is not only a risk factor for amyloid deposition and Alzheimer's, but is also a risk factor for this ARIA-E side effect or complication of the monoclonal antibodies. Rarely, ARIA-E occurs spontaneously or in the placebo group, but very low numbers. The other side effect is ARIA-H. So ARIA-H is hemorrhage. Some of this is removal of amyloid from the small blood vessels, causing leakage, or usually microhemorrhages, about the size of the head of a pin, so they're usually asymptomatic. Microhemorrhages accumulate just with normal aging. They accumulate even more if you have amyloid in your brain and blood vessels, and they accumulate even more if you are treated with an anti-amyloid antibody. So there is a background rate of ARIA-H or microhemorrhage accumulation in the placebo group, but is higher in the treated group. And so here are the percentages here. And again, you see this ApoE4 effect. So you have more microhemorrhages, approximately double your risk for every ApoE4 gene with ARIA-E and ARIA-H, because they often go together. So if you see ARIA-H 50% of the time, you also see some, if you see ARIA-E 50% of the time, you also see some ARIA-H. And I'll show you what some of these look like on MRI imaging. As far as symptomatic ARIA, 0 in the placebo group and 2.8% in the treated group. So only 2.8% symptomatic ARIA. So most of this is asymptomatic and only captured by MRI monitoring. So you see these abnormalities on MRI. So now you have the cost, you have the inconvenience, and you have the side effect of ARIA. What about the appropriate use? Who is the appropriate patient to get lecanemab? First, you have to make the diagnosis. They have to meet criteria for either mild cognitive impairment or mild dementia. And you have to prove that there's amyloid in the brain, either by spinal fluid analysis or by PET scan. Now, Medicare has told us that they would cover amyloid PET, but in practicality, this has not happened yet. So we think it will happen soon. But for now, it's been almost impossible to get an amyloid PET scan covered by Medicare. But we're hoping that's going to change soon. And the MMSE score should be 22 points out of 30. So if someone comes into the clinic and their MMSE is 21, we have to tell them, I'm sorry, your dementia is too advanced and you don't qualify for lecanemab. And it may not be covered by Medicare if your MMSE is lower than 22, which is kind of a difficult conversation to have. As far as inclusion criteria, they have to have MCI or mild dementia. They have to have amyloid in the brain. They have to have MMSE of 22 to 30, relatively medically stable. Other medications for Alzheimer's are perfectly acceptable, as were done in the studies. And they have to have a partner. someone who helps them navigate the healthcare system, the intensive monitoring system. They may not need a partner at the beginning, but as they progress, they will need a partner, and they become more demented. So we kind of have to insist on someone partnering with them as they go through this treatment course. And recommend also an informed consent signed by the patient accepting the risks of treatment. There are lots of exclusion criteria. Now, one of the exclusion criteria is more than 4 microhemorrhages at baseline. And as I said, these microhemorrhages accumulate with normal aging, so this also excludes quite a few patients who have some microhemorrhages already at baseline. Other dementia that's not Alzheimer's, other major medical illness, other immunologic illness, or receiving other antibody treatment. I'm not really sure if that's valid, but it's there. A bleeding disorder, because that would increase the risk of hemorrhage. Anticoagulant treatment would probably exclude patients from these antibodies, again, because of the risk of hemorrhage or the ARIA-H. Any unstable medical condition. So there are a lot of hoops, inclusion and exclusion criteria to get through to see if you qualify for the lecanemab treatment. As part of the FDA approval, they required a registry maintained by Medicare, CMS. So if you want to prescribe this drug, you have to enroll them in this registry and enter all of this data at baseline every 6 months until 24 months. So they want to collect this information post FDA approval. If they don't qualify for Medicare, there's another registry maintained by the Alzheimer's Association at alz.org. You have to enter the diagnosis, a MoCA score to demonstrate cognitive decline, a functional activity questionnaire score, clinical dementia rating score is optional. Demonstrate proof of amyloid, and whether there's anticoagulant use, antiplatelet use, or any RAE or H on MRI scans. As part of the approval, also, there was a black box warning for lecanemab. So this is for Leqembi, and they were particularly pointing out this risk of ARIA for the ApoE4 homozygotes. Anyone who's ApoE4/4, 50% of Alzheimer's patients treated with this class of medication have a higher incidence of ARIA, including symptomatic, serious, and severe ARIA, compared to heterozygotes and non-carriers. So they recommend ApoE genetic testing be done before anyone receives this drug. Unfortunately, genetic testing is also not covered by insurance and costs about $300 or so for self-pay if you send it out to Mayo Clinic or et cetera. So the VA healthcare system has incorporated Leqembi in their treatment for Alzheimer's, but they do not allow ApoE4 homozygotes to be treated because of this elevated risk of ARIA. And this is the monitoring plan. So most ARIA occurs within the first several months. So if you can get past the first several months, then you're probably okay. Your risk goes down, but there's a lot of MRI monitoring at the beginning of the infusions. So the infusions are happening every 2 weeks, as shown here. You get a baseline MRI scan to determine qualification for the Leqembi within a year, but the sooner the better, to starting the first dose. And then you start treatments, and then you get an MRI at the 5th, 7th, 14th infusions, et cetera. And then going forward, we're not quite sure how often to get MRI scans. But if anyone developed any new symptoms, any new headache, we would get an MRI scan to look for ARIA and potentially withhold treatment, either temporarily or permanently. So it's a pretty intense treatment and monitoring program. This is why we want a partner, study partner, to help them. As far as symptoms of ARIA, the most common is headache. After that, worsening confusion, or more sudden confusion, quickening confusion, more than expected for the rate of decline of disease, visual changes, all the way to cortical blindness, dizziness, nausea, gait difficulty, and then serious ARIA could also involve seizures, status epilepticus, encephalopathy, stupor, and focal deficits. And if the ARIA is asymptomatic, which most of it is, and is mild on imaging, which most of it is, you can continue treatment. If ARIA is severe, either in symptoms or in imaging, you discontinue treatment permanently. And if it's in between, you can suspend the dosing until the ARIA-E resolves, and the ARIA-E resolves after 1 to 2 months. The edema goes away. The microhemorrhages never go away. They put this sort of permanent iron tattoo on your brain from the iron deposition, the hemosiderin, but they can stabilize. So the ARIA-E goes away, the ARIA-H stabilizes, and then you can have a discussion about restarting the medication if it's in the middle here. So these are the recommendations. And this is another algorithm about when to withhold or suspend treatment temporarily or permanently. There are also a lot of stop rules. Any macrohemorrhage, more than one area of superficial siderosis, which is a hemorrhage on the surface of the brain. More than 10 microhemorrhages since the treatment began, more than 2 episodes of ARIA, severe ARIA, or patient required treatment with an anticoagulant, then you would want to stop the treatment. So let's talk about the next antibody. Any questions so far about that antibody? We'll end up with just one more antibody study, which is the Trailblazer study published in JAMA this year. And this is donanemab, a competing antibody. And this looked at 860 patients who got donanemab, 876 who got placebo, 277 locations around the world. Average age was 73. The primary outcome was the IDRAS, cognitive and functional measure, and again showed significant benefit of treatment compared to the placebo. Now, this study did something a little bit different. They divided people into high tau and low tau people and demonstrated better cognitive outcomes, clinical outcomes in those with the low tau, suggesting that if you started earlier, you would have more of an impact. They also stopped treatment once the amyloid PET scan became negative. So they figured, once you've removed the amyloid, why continue to treat with the antibody? So they stopped the treatment. And so that might be another strategy to go forward with in the future with these other antibodies, but this was the first. And this one demonstrated even slightly better than lecanemab, 35% slowing of decline in the primary outcome measure. So here's the decline in the treated group compared to the placebo group. Again, nobody got better, nobody improved, everybody got worse, but the treated group declined significantly less, statistically significant, and I think clinically significant less compared to the treated group. And it doesn't matter what outcome you looked at, and it doesn't matter if you looked at the low tau or the combined population, in general, the low tau people had better outcomes, slightly better outcomes compared to the entire population. And this is what happened to the amyloid plaque. So continued gradual accumulation of amyloid in the placebo group, 1 to 2% per year, 1 to 2 centiloids per year. And removal of amyloid in 24, 52 weeks after monthly infusion. So the previous antibody was every 2 weeks. This antibody is every 4 weeks infusion, and rapid clearance of amyloid from the brain. And this also demonstrated something happened to this slide when it went to PDF, but this also demonstrated improvements in the phospho-tau measures in spinal fluid, significantly better measures a decrease in phospho-tau compared to continued increase in the placebo group and the anti-amyloid treated group compared to placebo. But again, there were side effects, and this particular antibody had more side effects than the previous one. There were 3 deaths in this study out of 3 deaths out of 853 who died from ARIA. 1 died from ARIA-E and 2 died from ARIA-H, or hemorrhages, compared to 1 death in the placebo from the treatment, which I don't really fully understand how you can have 1 death from placebo, but it's in this chart. I don't understand that, but there were certainly 3 deaths from the drugs in this chart. And again, infusion reactions was a side effect in 0.5% of placebo compared to 8.7% in treated groups. So these temporary flu-like symptoms from infusing IV and monoclonal. And ARIA-E and ARIA-H were the major concerns, side effects. So, and again, showing this ApoE effect. As far as symptomatic, it was 0 in the placebo group and about 6% in the treated group. So only 6% had symptomatic ARIA. Most of it was asymptomatic. And again, increased ARIA-E and increased ARIA-H as a function of ApoE status, ApoE4 status. So doubling of risk for ARIA-E and ARIA-H for every ApoE4 gene. And this is what ARIA looks like. So all this white is edema shown on FLAIR imaging. And this is normal on this side. And this is edema, ARIA-E. This will resolve over 1 to 2 months. This is probably asymptomatic for this particular individual. Even though it looks bad, it's just fluid. It will resorb and return to normal. This is a more subtle ARIA-E with this leptomeningeal effusion here in the right temporal occipital region, shown on FLAIR imaging. So these are 2 examples of ARIA-E. Here's an example of ARIA-H. These black dots are microhemorrhages within this region of ARIA-E. So you often see ARIA-E and ARIA-H together. So these black dots are microhemorrhages. So that's ARIA-H. And here's a more subtle ARIA-H, which is a superficial siderosis in the left frontal region. Again, from hemorrhage as a result of inflammation and probably removal of amyloid from blood vessels. As far as deaths, with the double-blind study in lecanemab, there were none related to the treatment. With donanemab, there were 3 deaths related to the treatment, 1 from ARIA-E, 2 from ARIA-H. But now we've collected more information on patients in the open-label extension of those who got lecanemab. And 1 person died with ARIA-E from lecanemab and ARIA-H combination with more than 30 microhemorrhages. 1 person had a large hemorrhage after anticoagulant was started for AFib. A patient died of ARIA-H. And 1 person had an ischemic stroke, received TPA, and died of hemorrhage. Now, they could have, of course, died anyway from the hemorrhage, from TPA, or from the stroke, but they happened to be on lecanemab, so it was attributed to lecanemab, increasing the risk of ARIA-H. So there have been 3 deaths in the lecanemab treated group and 3 deaths in the donanemab treated group. So this is obviously, a risk of concern. And when some patients hear about brain swelling and hemorrhages, then they suddenly lose interest in getting these anti-amyloid antibodies. So lecanemab was deemed safe and effective for individuals with mild cognitive impairment and Alzheimer's disease, early Alzheimer's disease, FDA approved, Medicare covered as of July of this year. 27% reduction in the primary outcome measure, measuring cognitive and functional decline, which translates to about 5 months less decline out of 18. So, whether this translates into 10 months out of 36, et cetera, we don't know yet. We're still collecting that data. Donanemab, similar results, also will likely be approved in early 2024 for patients with mild cognitive impairment and early Alzheimer's disease, probably followed by Medicare coverage. And again, probably requiring that same registry and the same black box warning for ARIA, particularly for the ApoE4 homozygotes. 35% reduction in cognitive functional decline in those with a low medium tau burden, which translates to about 6 months less decline out of 18 for this particular antibody. But anyone have any comments now? Anyone would sign up for this treatment or not, given the inconvenience, the cost, and the side effect profile? And yet there's significantly less cognitive decline in the treated group compared to the placebo group. Anyone have any comments?
I have a question.
Yeah.
Is it a phenomenon that's been identified?
He comes in. I'll show you something later.
Okay.
The
What?
video that I told you.
I think it's sure Suzanne Parker's here.
Yeah. Okay.
Oh, nice. Okay.
Is it just
This-
a phenomenon after the antibody drugs came out?
So, yeah. So the question is ARIA, is this a new phenomenon? Has it just been, it's a new name for an
What?
old phenomenon. Our microhemorrhages have been around forever. And that's an example of ARIA-H. And the most ARIA-H is microhemorrhages.
Fran Rams announced something about.
But since the antibodies came out, it's renamed ARIA-H. The edema, ARIA-E, can occur spontaneously, but it's pretty rare. It may be related to people making their own anti-amyloid antibodies, And so you can get this sort of autoimmune ARIA-E without any treatment whatsoever, spontaneously, and that's probably been going on forever as well. But it's renamed now as ARIA-E since it's very common with these antibodies. So it's not a new phenomenon, it's a new name for an old phenomenon. Other questions? Yeah.
Given the strong association with apolipoproteins, I'm wondering what research is going on to look at the relationship between apolipoprotein alleles and the amyloid hypothesis, and is there an opportunity to intervene there, maybe more safely for any of this accumulates?
Yeah, so the question is about ApoE research going on. Why is ApoE a risk factor for amyloid deposition? Why is ApoE4 a risk factor for Alzheimer's? Why is ApoE4 a risk factor for ARIA? And basically, we don't know the answers to that question. There is a lot of research going on. There's a lot of putting all of these different variants in mouse models to try to understand molecular mechanisms, but we really don't know. There have been some attempts to try to do sort of like gene therapy for ApoE2, but of course, gene therapy is very difficult, particularly in the brain. But if we could figure out those mechanisms, there are probably other targets there as well that involve ApoE. Some of these ApoE mechanisms that we don't understand would lead to other targets and other therapies. So it's a great strategy, but it's, there's a lot to discover there. So we have a lot of work to do in the short term. Now we have this new drug. We were kind of overwhelmed before this drug was approved, and now we're even more overwhelmed, and we're sort of turning to our MedStar colleagues and asking them to help us set up this infrastructure to treat anyone who's interested and eligible in getting treated with these antibodies. We particularly would like to hire at least one nurse navigator, because it's a pretty intense treatment and monitoring schedule with a lot of, holding drugs for ARIA and restarting drugs, making sure that the MRI is done, making sure the MRI is read correctly before the next infusion. So there's a lot to keep track of. And so we really need some nurse navigators, perhaps RN or others, to help get patients through this system. We can't rely on the patient who has some cognitive challenges to do this themselves. So we really need, and as you can see, the ARIA can be quite serious, especially if you don't catch it early and you continue to treat and the ARIA keeps getting worse. So you would want to suspend the dose at times for the ARIA-E to resolve and catch it early so that it doesn't become more severe or symptomatic. CMS and insurance coverage for amyloid PET scan. In theory, it has been approved for coverage by Medicare, but in actuality, this is debatable as yet. So we hope that we'll, break that down soon. ApoE genetic testing is not covered by any insurance, and it's about $300. So we would like to know someone's ApoE status so we can have a better informed discussion about the risk, particularly the risk for ARIA-E and ARIA-H. We anticipate donanemab FDA approval and Medicare coverage early 2024. There's a study looking at subcutaneous lecanemab instead of IV, and it looks like it's equally promising or perhaps even better than IV. So this would make life easier if we could just do sub-Q injection instead of IV infusion every 2 weeks, particularly for those people who have no veins. And then there's the open label extension data that we're still collecting on donanemab and lecanemab. We're trying to develop these plasma biomarkers so that we can replace PET imaging and spinal fluid analysis in diagnosis, prognosis, measure of drug efficacy, and eventually use this for screening. We're doing plasma biomarkers to screen for our research studies, but so far this hasn't hit clinical application as yet. So we screen with a blood test, and this minimizes the number of negative CSF and PET scans in a research study and makes it easier and less expensive. For the longer term, we want to go to prevention. And so we're looking for volunteers now to join the AHEAD study. And the AHEAD study is lecanemab in people who are cognitively normal, but have amyloid in the brain. So we know they're headed in that trajectory towards MCI and early Alzheimer's disease, and we want to prevent that. So this is looking for volunteers now, and it's an IV infusion of lecanemab every 2 weeks for 4 years. Now, the people who joined this study are usually people who have Alzheimer's in their family, a family member, a parent, a spouse with Alzheimer's, or they may have found out by 23andMe or somehow that they're ApoE4 positive. So they know that they're at higher risk. And they're willing to sign up for this study, the inconvenience, the possible risk of the lecanemab every 2 weeks for 4 years. We're looking for 1,400 volunteers across the world, and we're about 60% enrolled now, and we're actively seeking volunteers. So would anyone join the AHEAD study? And of course, a lot of people don't want to know their ApoE status. They don't want to know their amyloid status. They don't want to know if they're going to get Alzheimer's or not, or if they have Alzheimer's or not. So they head for the doors and run in the opposite direction. But there are a group of people who want to be proactive and want to see if we can prevent Alzheimer's disease in this high-risk population. And then can we monitor amyloid burden, perhaps with plasma biomarkers? Should we stop treatment when the amyloid is gone, like sort of the induction and maintenance phase, or should we just carry on with the antibody treatment? What happens to ARIA risk over time? Does it really go down or go away? Can we increase the efficacy while decreasing the risk? Are there ways to do that? And some ways to do that are very careful patient selection. For example, anyone with more than 4 microhemorrhages wouldn't qualify because the risk of ARIA-H is presumably increased. Can we do combination therapies with other targets? And I think we probably will eventually if we have to figure out what these other targets may be. Can we do active vaccination instead of passive? So right now, instead of infusing an anti-amyloid monoclonal, can we just inject you with amyloid and you make your own antibodies? And some people do make their own antibodies. So that would maybe an easier approach. Is it safer? Well, not sure yet. And can we get to personalized medicine, which involves genotyping, finding out if you're ApoE4, and there are other risk genes as well? And should we do population screening with biomarkers? As far as the active vaccine, we started out doing an active vaccine way back in 2005, because this was obviously an easier approach than giving the passive antibody. The problem was that some patients developed a meningoencephalitis as a result of the vaccination with the A-beta amyloid protein or peptide. And so this was sort of shelved in favor of the passive approach. And it wasn't really picked up again until we started seeing success with the passive approaches. So now there are some early studies of this active vaccine. And the hypothesis is that if we can activate B cells without T cells, we might be able to get away without triggering these inflammatory autoimmune side effects, the meningoencephalitis and perhaps the ARIA-E and ARIA-H. But we don't know yet, and these are early days for these active vaccines, so there's a lot of work to be done to see if we can develop an active vaccine for Alzheimer's. So we're doing lots of studies in the memory disorders program at Georgetown. Some of these involve no treatment whatsoever. They're just biomarker discovery and validation. So we're looking at imaging biomarkers. We're trying to develop this inflammatory PET biomarker with our colleagues at NIMH. We're looking at the genetics and imaging biomarkers of early onset Alzheimer's, early onset meaning less than 60 or 65 years old. And we're looking at language, and with Dr. Harris, we're collecting brains. So we asked patients in our clinic if we can have their brains when they no longer need them to go into the brain bank and then do clinical pathologic correlations. We are still doing some treatment trials. Some of these do not involve antibodies, although we're continuing all the open label extension of the antibody studies. One of these is metformin. And as I mentioned before, there's this link of diabetes with Alzheimer's that we don't fully understand either. Obesity, diabetes, metabolic syndrome is a risk factor. Anti-diabetic drugs decrease risk, including metformin. So we're testing metformin to see if it can help in preserving cognition in people with mild cognitive impairment. And that's the MAP study. This is looking for volunteers. VivaMind is a drug that inhibits the amyloid accumulation. CT1812 is a drug that promotes misfolded protein clearance from neurons, such as the amyloid and the tau proteins. So we are trying other strategies and other targets, and these may be given eventually in addition to the anti-amyloid antibodies. And all of these studies are actively looking for volunteers. And then we're also doing a study for patients with very severe dementia with some mild agitation and testing THC CBD for patients at the end of life enrolled in hospice. So if you have any patients, any dementia, doesn't have to be Alzheimer's, any dementia severe in hospice with some agitation, we're testing CBD, THC, which patients love because all of our patients are taking CBD. We're also doing this prevention trial that I mentioned, testing lecanemab, and this is looking for volunteers. Please send anyone who's interested and eligible for research and their study partners. And this is what we're looking for. This is the ideal patient who, probably doesn't exist. But the ideal patient is somewhere in the AD spectrum. They could be normal, they could be MCI, they could be mild dementia, or this one study that's enrolling the patients in hospice. Relatively early, MMSE 20 to 30, not more severe than that. Usually age 50 to 90 is the typical for our clinical trials. And pretty medically stable, no active cancer, no cancer in the last 5 years. Medications relatively stable, have a study partner. We would like them to be MRI compatible if possible. Even MRI compatible pacemakers cause problems. So we want the patient to be MRI compatible and hopefully not on anticoagulant because some of our trials require spinal tap. And because all of our cognitive testing is in English, we kind of insist on English being a native language as one of the criteria. So this is sort of the ideal patient. We would love for you to refer these people to our clinic if they have any interest whatsoever in learning about research opportunities. Not necessarily just signing up for a study, but just learning about opportunities, because most people don't know that there are research opportunities available. A typical Alzheimer's study is 90% Caucasian, which means we know very little about non-Caucasian populations. And yet we know that Alzheimer's affects non-Caucasian populations even more than Caucasian. So we want to increase our representation of underrepresented groups. This is the definition here in the United States, what an underrepresented group is. And it's currently about 28% of the US population. So we should be able to match that in our clinical trials. And yet our typical clinical trial is only 10% underrepresented groups. So if you have any underrepresented group who meets these criteria, who's interested in research, we would really love to see these patients referred to us.
Dr. Turner,
Yeah.
Without asking you to give away any insider information, I understood that Dr. Musa and Dr. Pagan had a non-antibody anti-leukemic drug. I know it had pretty dramatic pilot data on Parkinson, but it was
Yes.
Anti-tau.
Yep. So this is another strategy that's been developed by Dr. Musa here at Georgetown, and he's testing it for many neurodegenerative diseases, including Parkinson's disease, Lewy body dementia, and Alzheimer's disease. And it's a tyrosine kinase inhibitor. These are approved. These are drugs approved for cancer, leukemias. And the strategy is that it promotes autophagy of these misfolded aggregated proteins. And it doesn't matter which protein it is. It could be alpha-synuclein in Parkinson's disease or Lewy body dementia. It could be amyloid or tau in Alzheimer's disease, or it could be other proteins. And so phase 2 studies have been done, and they look very promising and exciting, and they look like they have good results in biomarker results and clinical results. The trick is to get the phase 3 funded. And that's sort of where these studies have been sort of hung up. So we're trying to get a phase 3 of a tyrosine kinase inhibitor for Alzheimer's disease and for Parkinson's disease and eventually for Lewy body dementia, because this is a very promising strategy and it's starting to be picked up by other places as well. But this is a completely different target and could be an add-on to our other therapies as well. It's just these Alzheimer trials are so long, 18 months, and so large, 2,000 patients, that they become very expensive, especially when you throw in these PET scans, which means that the phase 3 trials are usually only funded by Lilly and Biogen. So it's difficult to get the funding to get to the phase 3, and that's sort of where they're hung up. So if you know anyone with an extra $100 million, and then finally, just this advertisement for this study. This is an NIH-funded study, and it's basically brain games. And so patients ask us, "Oh, if I do brain games, can I prevent Alzheimer's disease?" And it's like, well, if you want to do brain games, go ahead, but the evidence is kind of weak about whether this will help or not. But if you enjoy them, go right ahead and do them. So this is free brain games, and this is aptwebstudy.org. It's open to anyone who's 50 plus, and it's basically tests your cognition. And you can repeat it if you want to, every 3 months or, whatever you want to do. And it will track your cognition. Some people like to track their own performance over time, and it will track your cognitive status over time. And you can do these fun brain games at no cost. And if you do decline, it will point this out to you and say, well, you're declining, you might want to be checked out. And so it's a way to monitor yourself. And it's also a way for us to pick up early patients who may want to self-refer to a site near them who's doing research and learn about research opportunities. In the meantime, if people enjoyed brain games, then this is a free way to do it.